Hello friends, today we are discussing about the CRRT, what are the different modes, uses, indication, and when to stop, when to start, complication and everything. So we are discussing under the title of the prescription of CRRT. So this continuous renal replacement therapy delivers the gradual clearance of the solute, fluid balance control, and hemodynamic stability. CRRT does not appear to increase the survival compared to the intermittent renal replacement therapy, but may affect the renal recovery. However, we describe however we are describing here how to prescribe this CRRT. So first we'll understand what are the modalities of the RRT. Multiple modalities of the renal support may be used in the management of the critically ill patient with the kidney failure. This includes CRRT, conventional intermittent hemodialysis, and the prolonged intermittent renal replacement therapy, which are the hybrid of CRRT and IHD. IHD provides a rapid solute clearance in the ultrafiltration during relatively brief treatment, that is 3 to 5 hours. The continuous therapies provide the more gradual fluid removal and the solid clearance over prolonged period time, optimally 24-hour a day, but often interrupted due to system clotting or diagnostic or therapeutic procedure. The multiple forms of the PIRT are characterized by the treatment that are generally between 6 to 8 to 16 hour in duration, with slower rate of the solute clearance and ultrafiltration than IHD, but more rapid than the CRT. PIRT is the most commonly provided by using equipment similar to that for IHD, but with the lower blood and dialysate flow rate. It can also be performed by using equipment designed for the CRRT, but with augmented dialysate or ultrafiltration rate to achieve similar delivered therapy over shorter duration. So we'll see how to select this particular RRT modality. Although CRRT and PIRT are the most commonly used in the hemodynamically unstable patient, there is a marked variation in the practice. Some centers use CRRT or PRRT in ICU patient with renal failure, regardless of hemodynamic status, where other uses IHD with adjustment in the prescription, even in the vasopressor dependent patient. It must be recognized, however, to provide intermittent hemodialysis in hemodynamically unstable patient, the standard prescription may require modification, such as prolongation of treatment time to allow for more gradual ultrafiltration, use of higher dialysate sodium concentration, and reduced dialysate temperature. Although the kidney disease, improving global outcome clinical that is KDIGO clinical practice guideline for ACARE recommended the use of CRRT for patients who are hemodynamically unstable. The strength of this recommendation is very good. The CRRT is more effective in achieving net negative fluid balance than the IHD. In addition, the patient with the fulminant hepatic failure or brain injury with increased intracranial pressure, CRRT is associated with the better maintenance of cerebral perfusion than the IHD. Now, the selection of CRRT modality. While initially developed as an AV arteriovenous therapy, the most CRRT is now performed using pump-driven veno-venous extracorporeal circuit. Although this introduces additional degree of complexity, including pressure monitors and air detectors, pump-driven veno-venous circuit provides higher and more consistent blood flow and eliminates the hazards associated with the prolonged arterial cannulation with large bore catheter. Multiple techniques for delivering CRRT has been developed when used solely for volume management, and the treatment is known as slow continuous ultrafiltration. More commonly when provided as continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, or continuous veno-venous hemodiafiltration. CRRT provides both solute clearance and volume removal, with difference between these modalities related to the mechanism for the solute clearance. So in CVVH, high rate of ultrafiltration across the semi-permeable hemofilter membrane is created by the hydrostatic gradient and the solute transport occurred by the convection. So solute are entirely entrained in the bulk flow of water across the membrane, and the process is often referred as solvent drag. High ultrafiltration rate are needed to achieve sufficient solute clearance, and the ultrafiltration volume beyond what is required to achieve the desired net fluid removal is replaced with the balanced IV crystalline solution. This replacement solution may be infused into extracorporeal circuit either prior to or following hemofilter. Because the high ultrafiltration rate hemoconcentrates the blood as it passes through the hemofilter fiber, the risk of sludging and the fiber occlusion is increased. Pre-filter infusion of the replacement fluid dilutes the blood entering the hemofilter, mitigating this hemoconcentration. However, pre-filter administration of the replacement fluid dilute the solute content of the blood, reducing the effective solute clearance at fixed ultrafiltration rate. Post-filter infusion has no such effects. In CVVHD, dialysate is perfused across the external surface of the dialysate membrane, and solute exit from the blood to dialysate by diffusion down their concentration gradient. Ultrafiltration rates are relatively low compared with those in the CVVH, permitting net negative fluid balance without the need for IV replacement fluids. CVVHDF is the hybrid combining dialysate flow of CVVHD with high ultrafiltration rate and the use of replacement fluid of CVVH. The various mechanism of solute clearance provided by CVVH and CVVHD results in different profiles of solute removal with each modality. Diffusion provides efficient clearance of low molecular weight solute, that is within the range of 5,000 to 1,500 500 to 1,500 Dalton. However, diffusive clearance declines rapidly as the solute molecular weight increases. In contrast, the solute movement in the convection is limited primarily by the size of the pore in hemofilter membrane. The clearance of the lower and the higher molecular weight solute are similar until solute molecular radius approaches the size of the membrane. Thus, at equal effluent flow rate, CVPH provides higher clearance than the CVVHD for solute in the range of 1,000 to 20,000 Dalton or even higher if high cutoff membrane with large pores are used. Although it has been suggested that augmented clearance of high molecular weight, that is pro-inflammatory cytokine, are provided by CVVH, it is might be beneficial. This has not borne out in the clinical practice. So, independent of diffusion or convection or adsorption of the solute in CRRT circuit, subject to saturation of the membrane binding site, may also contribute to the overall solute clearance. So the choice of the CRRT modality, whether we should go for CVBH or CVBHD or CVBHDF, is primarily the function of the provider preference rather than the patient characteristic or the objective outcome data. So this is the schematic diagram of the modalities of the CRRT. Now this explains the mechanism by which CRRT works, which is mainly convection and the diffusion. So the convection solute transfer across the membrane via entrainment of the solute in the bulk flow of the water through during ultrafiltration, and the higher molecular weight solute that is represented by the larger symbol, and the lower molecular weight solute are transported across the membrane with the equal efficiency until the molecular radius of the solute exceeds the uh, membrane pore size. And the other mechanism is the diffusion, in which solute transfer across the membrane occur by the movement down the concentration gradient from blood to the dialysate, that is a lower molecular weight solute cross the membrane more readily than the higher molecular weight. So, what are the indication for the initiation of the RRT? The indications are volume overload, metabolic acidosis, electrolyte abnormalities like hyperkalemia, hypernatremia, hyperphosphatemia, uremia. That is uremic manifestations like uremic encephalopathy, uremic pericarditis, persistent and the progressive acute kidney injury. Now we'll see the volume overload. Volume overload in the AKI occurs due to disruption of the kidney's ability to maintain the fluid balance in the face of administration of the IV fluids, blood product, and the other medication required for resuscitation and supportive treatment of the critically ill patient and may develop even in patients who are not oliguric or anuric. RRT is generally indicated when the volume overload compromises organ function and is refractory to the diuretic agent. The strong association exists between the severity of the volume overload at initiation of RRT, mortality risk, the casualty has not been established. A complex interplay exists between the underlying severity of the illness, development of the volume overload, and mortality. There is the absence of the prospective data showing the initiation of extracorporeal ultrafiltration at specific threshold of volume overload reduces the mortality. Now, the next indication is acid-base abnormality. Progressive metabolic acidosis is an inevitable consequence of the kidney failure developing due to impaired renal acid excretion. In patients in whom severe acidosis is refractory to the medical management, such as volume overloaded patient who cannot tolerate alkali administration, either intermittent or continuous RRT is effective. Commonly suggested threshold for initiation of RRT is pH less than 7.1 or 7.2 and serum bicarbonate level less than 12 to 15. Earlier initiation of RRT may be necessary in patients with acute lung injury receiving lung protective ventilation, as severe acidemia can result from combination of metabolic and respiratory acidosis. Although RRT augments the lactate clearance, there is scant evidence that initiation of RRT to augment lactate clearance alter the clinical outcome in patients with lactic acidosis is not associated with the drug toxicity, for example, metformin. Now, severe electrolyte abnormality. Multiple electrolyte abnormalities are associated with the AKI. Severe hyperkalemia is the most life-threatening and requires the prompt treatment to prevent cardiotoxicity and arrhythmia. Initiation of RRT is indicated when hyperkalemia is refractory to medical therapy or recur following the initiation treatment. RRT solely for the management of hyperkalemia is rarely appropriate when the potassium levels is more than 6. So the RRT generally appropriate in whom potassium level remain more than 6.5 despite medical management. Although IHD although the IHD provides more rapid correction of hyperkalemia and is preferred modality in this setting. CRRT is effective albeit slower in the control of plasma potassium concentration. Other electrolyte abnormalities such as severe hyponatremia, hypernatremia, and severe hyperphosphatemia may accompany AKI and should be the factor in the decision to initiate RRT. In patients with the severe hyponatremia in the setting of AKI, CRRT may permit the slower and the more controlled correction of sodium concentration needed to prevent neurological sequelae of osmotic devalidation compared to the IHD. Now, regarding uremia and progressive or persisting leukemia. The use of RRT for the management of the overt uremic symptoms such as encephalopathy, pericarditis is well established. Other manifestations of uremia such as platelet dysfunction, impaired nutrition, increased susceptibility to infection and sepsis, heart failure and pulmonary edema may be difficult to distinguish from the other etiologies in critically ill patients with the multiple organ dysfunction. It is far more common when specific indications are not present for RRT to be initiated prophylactically in response to persistent and the progressive azotemia prior to the development of overt uremic manifestation. Regarding drug and toxin removal, a variety of the toxin and drugs such as toxin, alcohol, lithium, salicylate, valproic acid, metformin are dialysable, and timely use of RRT in case of poisoning and drug intoxication with this agent may be able to avoid serious complications. The ability of the RRT to remove particular drug or toxin from circulation is function of its size, volume of distribution, and protein binding. Thus, RRT is effective for the removal of smaller non-protein bound molecule with volume distribution less than 1 liter per kg of body weight. However, because the goal in the treatment of intoxication overdoses is the rapid clearance of offending agent, IHD is preferred over CRRT in this setting, even in patients who are hemodynamically unstable. The role of RRT in the management of hyperammonemia is uncertain. Based on the molecular weight, ammonia is readily cleared by diffusion and convection. As with the treatment of poisoning and intoxication, IHD will provide more rapid reduction in blood ammonia level. However, in small case series, high dose CRRT has been shown to be efficacious for acute management of severe hyperammonemia in infant with the inborn error of metabolism. The role of CRRT in adults with hyperammonemia complicating liver failure is less certain. CRRT is associated with the reduction in plasma ammonia levels. In retrospective analysis of registry data, CRRT was associated with improved 21-day transplant-free survival among patients with acute liver failure compared with IHD or NOAL. However, these data are not sufficient to establish the causality and there are no prospective studies that have specifically evaluated the use of CRRT for management of hyperammonemia in liver disease. The timing of initiation of RRT. In the absence of specific indications, the optimal timing for initiation of RRT in AKI is uncertain. Earlier initiation of AKI allows the optimization of volume status and early correction of acid-base balance, electrolyte disturbances, and control of azotemia prior to the development of major metabolic disturbances that served as objective indication. However, these potential benefit of early initiation need to be balanced with the risk and the burdens associated with RRT, including vascular access, for example, hemorrhage, thrombosis, vascular injury, infection, interdialytic hypotension, and resource utilization, as well as with the potential concern that RRT may impair subsequent recovery of the kidney function. This is the overview of the trial, which is associated with which explains the timing of the initiation of the RRT in AKI. Now we'll see the dose of CRRT. So the dose of CRRT is assessed based on the effluent flow rate, the sum of the dialysate and the total ultrafiltrate flow. So during CAVH, the concentration of the low molecular weight solute, such as urea in the ultrafiltrate, is close to that of the plasma water. Similarly, during CVVHT, because dialysate flow rate is commonly in order of magnitude lower than that of the blood flow rate, virtually complete equilibration of low molecular weight solute is achieved between the plasma and dialysate. Thus, regardless of modality of CRRT, clearance of urea and other molecular weight solute is approximately equal to the effluent. According to renal study and 18 study, CVV-HDF at effluent flow of either 25 to 40 ml per kg per hour. On the basis of these data, KDIGO clinical practice guideline recommended the target dose of CRRT of 20 to 25 ml per kg per hour, noting that higher prescribed dose may be required to ensure delivery of this target dose. Now the next is volume management. The second dimension to the prescription of the RRT is the volume management. So the net ultrafiltration may be adjusted independently of the solute clearance. As previously discussed, the severity of the volume overload is strongly associated with the mortality risk in both children and adults with the RRT requiring AQ. However, optimal strategy for volume management are uncertain, requiring balance between provision of net ultrafiltration to achieve euvolemia, optimization of cardiopulmonary status, and the risk of exacerbating hypotension. Management must be individualized for each patient with frequent assessment of the ultrafiltration time. It should be recognized that the short-term fluctuation in the BP generally unrelated to the volume status and that transient hypotension during CRRT needs to be carefully assessed for non-volume mediated factors and often requires management independent of alterations in the ultrafiltration time. Now, the next is role of CRRT in sepsis. Although the cytokine modulation by CVVH is proposed as an adjunctive therapy in sepsis, clinical trials have not shown any meaningful benefit. In the trial of 80 patients randomized to receive isovolumic hemofiltration or usual care, there was no improvement in the clinical parameters or mortality with hemofiltration. Similarly, in the high volume versus standard volume hemofiltration for septic shock patient with AKI, that is ivoretriol, which compared CVVH at 35 to 70 ml per kg per hour in patient with septic AKI, no benefit was associated with the high dose of hemofiltration. Thus, current data do not support the use of CRRT as an adjunctive therapy in sepsis beyond its role for the searing. Now, regarding technical issues in the CRRT management. The initiation of CRRT requires vascular access, which is generally established through the placement of large bore double volume catheter in the internal jugular, femoral, and subclavian vein. In the adult, catheter design and position must be sufficient to sustain blood flow rate of 200 to 300 liters per minute. Cannulation of the right jugular vein is preferred over the left, given the straight course of the right side to the right atrium. Although femoral catheter are generally associated with a higher rate of bacteremia than the internal jugular catheter, and comparable rate of colonization bacteremia thrombosis were observed with the femoral and internal jugular dialysate catheter in randomized controlled trial of 750 patients with RRT requiring it. However, the relative risk for the femoral catheter colonization was higher in patients with the BMI more than 28.4 kg per meter square. Subclavian cannulation is generally avoided because of the high risk of insertion complication and because of the risk of subsequent venous stenosis. Based on this consideration, KDQ clinical practice guideline for AKI recommended right internal jugular vein as the preferred location for catheter placement, followed by the femoral and the left internal jugular. The proper positioning of the catheter tip is critical for adequate catheter function. For internal jugular catheter, catheter tip should be at the junction of superior vena cava and right atrium and in the right atrium or in the right atrium, depending on the catheter design, rather than more proximally in the superior vena cava. To permit proper positioning, longer catheter is required when the left internal jugular vein is cannulated than when the right is used. Even longer catheter are required for the femoral catheter to permit placement with the catheter tip within as close to the inferior vena. Catheter malposition is associated with the restricted blood flow and the increased risk of recirculation. In addition, the catheter malfunction is a frequent cause of interruption in the circuit flow and the filter flow. So the adequacy of catheter function should be assessed whenever there is frequent system clot. Although the tunnel catheter are not recommended for routine use, they are associated with a decreased risk of infection and high blood flow rates and should be considered when the need of RRT is expected to exceed 1 to 3 weeks. Now regarding the anticoagulation for CRT. Clotting of the extracorporeal circuit is the most common complication during CRT. So the practice pattern regarding the use of anticoagulation vary widely, with estimates of 30 to 60% of patients undergoing CRRT without anticoagulation. Although use of anticoagulation is often avoided in patients who are coagulopathic, thrombocytopenic, and having active hemorrhage, anticoagulation-free treatment may also be successful in the absence of coagulopathy and thrombocytopenia. Strategies to minimize the risk of clotting in extracorporeal circuit include the following. Use of higher blood flow rate, minimization of the filtration fraction by using CVVHD rather than the CVVH, or by infusing replacement fluid pre-filter during CVVH and CVVHDF. Ensuring the optimal catheter function and responding promptly to machine alarm to minimize interruption in the blood. Increasing the frequency of scheduled replacement of the extracorporeal circuit. In the absence of anticoagulation, increased vigilance is required to ensure there is no compromise of delivery dose. When anticoagulation is used, the most common strategy relies on the heparin or citrate. Either unfractionated weight heparin or low molecular weight heparin may be used. Dosing protocol for unfractionated weight heparin during CRRT vary widely, ranging from the very low dose, that is initial bolus of 500 to 1000 unit, followed by the infusion of 300 to 500 unit per hour, designed to minimize systemic effect, to bolus dose of 30 unit per kg, followed by the infusion of 5 to 10 unit per kg per hour, with targeted systemic activated partial thromboplastin time of 1.5 to 2 times the upper limit of normal. So the low molecular weight heparin have been proposed as an alternative to ultra unfractionated heparin. Given the high anti-factor 10A activity, a more consistent anticoagulant response, and the lower incidence of heparin-induced thrombocytopenia. However, consistent superiority of the low molecular weight heparin compared to unfractionated weight heparin has not been shown. In patients with the heparin-induced thrombocytopenia, all heparin anticoagulation should be discontinued, and anticoagulation with the direct thrombin inhibitors are initiated. Argatroban is generally preferred, however, it is hepatically metabolized. In patients with both liver failure and AKI, bivalirudin is preferred given its given is significant non-renal and non-hepatic metabolism. The use of citrate as an anticoagulant is based on its rapid chelation of calcium in extracorporeal circuit, inhibiting multiple calcium-dependent steps in coagulation cascade. The citrate calcium complex dissociated in systemic circulation, and the citrate is rapidly metabolized, serving as an alkalizing agent. Citrate is infused into extracorporeal circuit with the goal of reducing ionized calcium concentration to less than zero point 0.4 mol per liter. Because some of the citrate calcium complex is lost in the effluent, systemic infusion of calcium is required to prevent hypocalcemia. Regional citrate anticoagulation is associated with the improved circuit patency, lower risk of bleeding, and avoidance of risk of heparin-induced thrombocytopenia compared with the heparin. However, citrate anticoagulation is associated with the increased risk of multiple electrolyte and acid-base disturbances. Close monitoring of the both circuit and systemic blood ionized calcium level is required to ensure sufficient efficacy without systemic hypocalcemia. Hypernatremia may result when hypertonic citrate solution are used. Because metabolism of citrate potentially yield the bicarbonate in 1:3 ratio, citrate anticoagulation may predispose to the development of metabolic alkalosis. In addition, patients with the severe liver disease or the other impairment in the citrate metabolism, citrate may accumulate and contribute to the high anion gap metabolic acidosis. Thus, in addition to the monitoring the ionized calcium in the extracorporeal circuit to ensure adequate calcium chelation, systemic electrolyte, magnesium, total and ionized calcium, blood pH need to be monitored frequently. Recommendation are to check this lab reading 1 hour after initiation on making any change in the citrate anticoagulation or CRT prescription, then at least every 6 hours. Citrate accumulation should be suspected if the need for calcium infusion to maintain systemic ionized calcium level increases, or if there is increasing anion gap metabolic acidosis, or if the ratio of systemic total calcium to ionized calcium is more than 2.5. If citrate toxicity is suspected, the use of citrate should be suspended or discontinued. Now, the drug dosing during CRT. Medication dosing during CRRT can be challenging because of the drug dosing. Need to account for multiple factors beyond the extracorporeal drug removal, including non-renal clearance, residual kidney function, and changes in the volume of distribution and protein binding. Errors in the drug dosing can lead to both toxicity from inadequate dose reduction and treatment failure from underdose. The latter of particular importance for antibiotic dosing in patients with sepsis accompanying their AKI. Medications such as analgesics, sedatives, vasopressors, which have an observable clinical effect, dosing should be titrated to preserve clinical response. Drugs with a higher molecular weight that are highly protein bound or that have very large volume of distribution will be poorly cleared by CRT, and dosing does not need to be adjusted for RRT. So the extracorporeal clearance of the low molecular weight drug that are non-protein bound will approximate the effluent flow, and for protein bound drug, the estimated clearance need to be adjusted for percent unbound fraction. For all medication with a readily measurable blood level, dosing should be adjusted based on the pharmacokinetic monitor. Finally, it must be recognized that although published guides provide estimate for dosing of many agents, they provide only general parameters that may not correspond to specific CRRT modality and dose used. Now, regarding nutritional management, patients with the AKI who are undergoing CRRT are usually in substantially negative nitrogen balance due to a high protein catabolic rate. In addition, CRRT results in amino acid loss as well as losses of the water-soluble vitamin and other micronutrients. Caloric intake of approximately 35 kcal per kg per day should be provided, with target protein intake of 1.5 gram per kg per day and with supplementation of water-soluble vitamin. Although enteral feeding is preferred, parenteral support may be necessary. Now, regarding complication of CRRT, as with all medical interventions, CRRT is not without its risk. Initiation of CRT requires placement of large bore central venous catheter that may need to be maintained for prolonged duration. Well recognized complication of catheter insertion include vascular or visceral injury resulting in hemorrhage, pneumothorax, and AV fistula formation. Prolonged catheter use is associated with venous thrombosis or stenosis. Blood exposure to the extracorporeal circuit may trigger immediate allergic or delayed immunological reaction secondary to cytokine activation. Bradykinin-mediated membrane reaction have been associated with certain synthetic membrane in conjugation with the use of ACE inhibitor. Air embolization may occur at the time of catheter insertion or removal or at any time during treatment if air is entered into circuit beyond the return line air detector. The most common complication during CRRT is circuit clotting, and the most common reason for circuit clotting is inadequate catheter function, resulting in the flow restriction and pressure alarm that interrupt the blood flow. Prompt catheter placement may be necessary if blood flow of 200 to 300 ml per minute cannot be sustained. Excessive filtration fraction may lead to hemoconcentration within hemofilter, also contribute to the filter clotting. If there is no catheter dysfunction, blood flow is maximized and the filtration fraction is less than 20%, initiation or intensification of anticoagulation should be considered. Complications of heparin anticoagulation can include bleeding and heparin-induced thrombocytopenia. Citrate anticoagulation may result into citrate toxicity from citrate accumulation and overt hypocalcemia from inadequate calcium replacement, both metabolic acidosis and metabolic alkalosis. Electrolyte abnormalities during CRRT are common. Hypophosphatemia may result from the continuous removal in extracorporeal circuit and can delay weaning from mechanical ventilation. Hypophosphatemia may be avoided by preemptive enteral and parenteral phosphate supplementation or by the use of phosphate containing dialysate or replacement fluid. Other electrolyte abnormalities are less common, although hyponatremia, hypernatremia, hyperkalemia have resulted from compounding error in custom manufacturer dialysate in the replacement fluid. To monitor electrolyte status, lab monitoring should be performed at least daily during the treatment. Unlike conventional IHD, dialysate and the replacement fluid are usually not worn. Modest thermal loss during CRT causes vasoconstriction and are believed to contribute to increased hemodynamic stability, but may mask the onset of fever. If thermal losses are more substantial, significant hypothermia may ensure and necessitating the aggressive external wall. Hypotension during CRRT is common, occurring in some series in more than one-third of the patient, but most often unrelated to the CRRT procedure. Ultrafiltration exacerbating the hemodynamic instability is most common treatment related factor contributing to hypotension. Negative inotropic and vasodilating properties associated with the acetate and lactate buffer solution previously contribute to treatment-related hypotension. However, the availability of the bicarbonate buffer dialysate and replacement fluid, these scenarios no longer has a significant consideration. So hypotension may also be seen during initiation of treatment, particularly if circuit prime is not reinfused. The result has been of particular concern in pediatric patients and may be mitigated by using albumin to the prime center. When hypotension is associated with the volume depletion, it should be treated with volume reinfusion and adjustment in the ultrafiltration pattern. In other circumstances, alternative etiology should be considered and hypotension managed with the titration of vasopressor support. Now, these are the complications associated with the CRT, which includes catheter-related complication, which is hemorrhage, infection, venous thrombosis, venous stenosis, traumatic AV fistula, hemothorax, air embolism, visceral injury, extracorporeal circuit-related complication like allergic reaction to hemodialyzer, hemofilter, tubing, circuit thrombosis, hemolysis, air embolism, hypothermia, hypotension, electrolyte disturbances like hypophosphatemia, hypokalemia, hypocalcemia, hypomagnesemia. Now, regarding discontinuation of CRRT, an initial manifestation of the recovery of the kidney function is increased urine output, although specific criteria are sparse. In the observational beginning and ending supportive therapy for kidney study, that is best kidney study, a urine output of more than 400 ml per day without concomitant diuretic therapy was the predictor of successful CRRT discontinuation. In this observational cohort, patients who were successfully discontinued from CRRT without requiring reinitiation were more likely to survive to hospital discharge compared to those requiring reinitiation of CRRT. In another study, a urine output more than 500 ml per day was proposed as the criteria for discontinuation of RRT in study of initiation and discontinuation of therapy in patients with the AK. In the ATN study, a 6-hour timed urine collection was obtained when urine output was more than 750 ml per day. RRT was continued if the measured creatinine clearance was less than 12 ml per minute and was discontinued if it is more than 12 ml per minute and was left to clinician judgment if measured creatinine clearance was between 12 to 20 ml per minute. Although this strategy can inform clinical decision making, a precise criteria for discontinuation for RRT are lacking. The transition of the patient from improved hemodynamic status but persistent ACAT to other modality of the RRT is highly variable. Now, the prolonged intermittent renal replacement therapy may be used as transitional therapy, or patient may transition directly to IHT as a clinical status warrant. Transition from CRRT to the PIRT or IHT may facilitate the initiation of physical therapy and mobilization out of the bed. In general, patient with the persistent RRT dependent AKI must be transitioned to IHT prior to ICU discharge. Thank you.